Hello, and welcome to another edition of the JASN podcast. I'm Kurella Tamura, Deputy Editor of Clinical Science at JASN. And today I'm joined by Dr. Ladan Golestaneh from Yale University School of Medicine. Dr. Golestaneh is the first author of an exciting new paper at JASN entitled Effective Peer Mentorship on Hospitalizations Among Patients Receiving Maintenance Hemodialysis. Welcome.
Thank you so much for having me and inviting me to this podcast.
Of course. So I'm curious, I'll start off by just asking, I'm curious how you got interested in this field. Would you mind sharing that sort of background with our readers before we dive into the paper?
No, not at all. I can just start a little bit with my professional background, I guess. So I've been an academic nephrologist since, training at Albert Einstein Montefiore. I remained there for 20 years and was a clinical nephrologist that then became interested in research and got a master's in clinical research methods. About 12 or 13 years into my into my clinical work, which is a little bit unusual. But what struck me, especially in places like the Bronx, where Montefiore or Albert Einstein is, was that, kidney failure seems to occur at epidemic rates. And as a clinical nephrologist, you just feel this sense of helplessness over the sheer number of patients whom you start on dialysis. And I was medical director of several of the outpatient dialysis facilities in the Bronx and also the inpatient dialysis facility at Montefiore for over the years. And the sheer magnitude of the problems was, hit home. And so right around the time when I was getting my master's, I became involved with Montefiore's care management organization, which actually is an organization that started contracting with payers to provide care for designated populations and assume financial risk and responsibility for them. And this was back in the 90s. So this was like before, value-based care models were really a thing. So they were really forward thinking in that sense. But boy, were they struggling with the dialysis population because, as you can imagine, their care needs are so unique and they were so expensive. So I kind of joined that organization part-time, and I helped them with the dialysis population, kind of figuring out ways and trying to create programs to reduce the cost and some of the morbidity and mortality of the dialysis patients. And that led to me becoming a clinical lead for the CKCC program that Montefiore was a part of back in 2022. And so as part of this work, I thought, well, frequent hospitalizations, I think, are pretty low-hanging fruit in terms of savings in this population. So I helped the CMO kind of develop these niche programs, mostly led by emergency department of physicians and nephrologists to really help reduce preventable hospitalizations through better coordination and communication. But while we were doing this, one of the things I observed was, trying to understand why these individuals who were hemodialysis patients, they go to the hospital so much, but it seemed like their job really was to just show up and stay for the duration. And it didn't seem like they were really contributing that much to their own care, that they were being cared for. And to me, that seemed like a lost opportunity. And so to make a long story short, in August of 2024, I moved to Yale, and actually a part of my job now is I work for the Centers for Outcomes and Research Evaluation, which is also known as CORE. And they're contractors for CMS, and they develop quality measures. So it was like going to the other side almost. And I've been involved with some of the contracts from the Innovation Center around, the kidney care contracting programs and the IOTA model. So it's an interesting perspective that, to be able to see all sides of the dialysis machinery. But all of this to say, the patient's perspective seemed to be missing, and the opportunity of the patient's ability to kind of change their own course of care also seemed to be missing, which sparked interest in this research study. And that was a very long answer to your question.
Well, I love it because I think that story will resonate with a lot of people who are listening to this. It sort of like puts its finger on, one of the things that sort of gnaws at you if you're a provider in hemodialysis care. So I love hearing these, motivational or, journey stories.
Yeah.
Let me ask a question first to sort of set the stage, which is what do we mean when we say self-management? And especially like what do we mean when we talk about self-management for hemodialysis? Because I'll admit my concept of self-management, my brain automatically thinks about home dialysis. And so like let's set the stage for listeners if you could just tell us like what you mean by self-management.
Yeah, I mean that's a really good question. It's not that intuitive for hemodialysis, but self-management basically describes, I think, the process by which, patients become active participants in their care. That for hemodialysis, we see that commonly for home dialysis modalities, right? So these patients undergo training and they take ownership of administering the therapies themselves. And that's something that comes naturally cognitively for us. Like, oh yeah, they self-manage. They actually lead the charge of their treatment. But I always think about as an example of self-management that person who was diagnosed with diabetes or insulin-dependent diabetes, and they have no choice but to self-manage in a sense. So they go through a series of sessions with a diabetes educator, and they learn about diet, serum glucose, how to self-administer insulin, and they also learn about what symptoms to monitor, for example, for hypoglycemia or diabetic ketoacidosis. So in that sense, of course, self-management needs to be taught in those instances. And I think that home dialysis is also a case in point of how it can be taught. I think that for patients on hemodialysis, self-management can also be taught. And we can see that by those patients who self-cannulate, by patients who learn home hemodialysis, and also these newer programs within the in-center dialysis facilities where the patients actually monitor and control their own treatments using a computer interface. But for most patients, I think that self-management involves really understanding fluid metrics, how the estimated dry weight works, and how they can use this knowledge to help them avoid becoming fluid overloaded or becoming, in that sense, volume depleted or hypotensive, and they can become an active participant, for example, in changing the estimated dry weight prescription. Or even if you were to take it a step further, they can self-advocate for extra time on the machine if they happen to have a high interdialytic weight gain for that session, or even ask for an extra treatment. Why not, where available? These things, if you cut out the middleman, then the treatment and the efficiency of the treatment will improve dramatically. And of course, while this will reduce hospitalizations, for example, related to acute fluid overload episodes, don't forget the damage of chronic fluid overload and resultant, pulmonary hypertension and heart failure that these patients face. And we as doctors, I'm afraid to say, under-recognize frequently, and how that can also be improved if the patients were only to understand their symptoms and how they relate to fluid metrics. So that's really just an example. We had other self-management skills around what uremia feels like and how that may be related to malfunction of the dialysis access, what to look for when your dialysis access is not performing optimally. That's also a self-management skill that patients can learn and report ahead of a hospitalization, and probably reduce, weight loss from malaise or uremia that would result from that. And then finally, just those symptoms that can be easily dealt with in the outpatient setting can also, I think a lot of patients, when they first enter dialysis, they don't understand the structure and how the dialysis facility works in the context of the larger, healthcare provision. So the kind of teaching those simple pragmatic skills, I think will go a long way for self-management.
Yeah, thank you for that explanation. So, like for those of us and the other listeners out there who aren't as familiar with the evidence in this area, is there evidence that certain methods for teaching self-management work either in the dialysis population or in other chronic conditions?
Well, I think, again, to use peritoneal dialysis as an example, I think, yes, there are models wherein self-management can be taught very successfully. And I think that the structure of a lot of these models involves a great deal of support, obviously didactics, and this notion that we at the CMO at Montefiore really try to leverage a nurse being available at all times by telephone should you run into problems at home. I think what a lot of us underestimate is just how daunting it is to not only receive a diagnosis of kidney failure, but then to have to take care of aspects of the disease at home by yourself. And I think there's a lot of intimidation and fear sometimes that goes into that, and anxiety that goes into that needs to be reduced. And so, for anyone who's worked with home dialysis patients, I think the peritoneal dialysis nurses and the staff are really heroes in this process. And they are not just the nurses who teach them the methods of peritoneal dialysis and later test them on it, but they also become a source of social support, emotional support. And they're always available, or someone's always available for them to call. And we don't do that well with hemodialysis. Hemodialysis seems much more impersonal and prescriptive. And even though I think I don't want to undermine the relationships that hemodialysis patients, develop with their technicians and the nurses in the dialysis unit, but there's not this shared responsibility and that kind of alignment of purpose, I feel, in the in-center dialysis world. So I think that, home dialysis and anyone really dealing with complex comorbidity like diabetes, I think those are self-management models that can be taught successfully and have worked, definitely work well. So.
Those are such insightful observations, I think. Let's transition to talk about the paper. So, tell our listeners a little bit about the design of the PEER HD trial and the inclusion criteria. How did you go about thinking through who should be the target of this intervention?
Yeah, that's a really good question. That this is where experience as a clinical nephrologist mainly comes into play. I'm not going to say the transition to doing research was easy, but it was definitely informed by the thousands of hours of patient care. The design of the PhD trial, it was a multi-center pragmatic randomized controlled trial, and these were patients receiving hemodialysis in dialysis facilities in the Bronx, affiliated with Montefiore, and also in Nashville, affiliated with Vanderbilt. And so there were actually two populations that were enrolled in the study. One population was the mentors, and the other population was the patient participants who were randomized. And we started with enrollment of the mentors, and we enrolled 16 mentors total. We used 10 of them at any one time between the two sites, and we had some backup mentors in case, the primary ones were unable to do some of the tasks because of illness or what have you. And these mentors were actually patients who themselves were receiving hemodialysis. And we had inclusion-exclusion criteria that basically defined them as being patients, mostly identified by the dialysis staff, by the way, that were adherent, engaged, hadn't been to a hospital, were clinically very stable and experienced. And like I said, these mentors were screened by the staff, and we also got some referrals from fellow nephrologists. And then as far as the patient participants, we had 200 patient participants, and eligibility of those, we thought through this carefully. We wanted at risk for hospitalization participants. And so the way we defined them were, these patients were new to dialysis, within 90 days, or had catheter access, or had a pattern of previous hospitalization, or had missed or cut treatments in the prior month, or they had interdialytic weight gains that were high. So if you wanted to write a paper on risk factors for hospitalization, you could basically look at our eligibility criteria for our patient participants. And so after we defined them, mostly through nephrologist referrals and dialysis staff referrals as well, we did the baseline visit and randomized them to usual care intervention. And basically the usual care participants were those that they just got a packet of information about dialysis and life on dialysis. And those randomized to peer mentorship were then contacted by assigned mentors. We assigned them for a total of 3 months. They were contacted by telephone on a weekly basis. And after that, they entered into an observational period for anywhere from 9 to 15 months. And, the primary outcome was emergency department visits or hospitalizations. And that was actually difficult to collect that data because, relying on the dialysis facility EMR was tricky, of course, because that doesn't capture all hospitalizations. And so we combined dialysis facility, hospital facility, electronic medical records, and we actually called the participants every month, asked them if they'd been hospitalized over the last month. But I just also wanted to point out that our patient population was mostly minoritized patients, which is unique. I think something like 50%, 57% of them were Black and 39% of them were Hispanic. So that was something that was unique to our patient populations at the two sites.
Mhm. We might circle back to that point, I think, at the end to maybe
Yeah.
talk about how peer mentorship might be uniquely suited for that population in some way. Tell us a little bit about the training that the mentors received. Like, how much training did they get, and what were the topics that they were trained on?
That's a really good question. We actually published a paper about the feasibility of the training program. But essentially, the mentors received 4 training sessions of 2 hours each. And at Montefiore, because this was before COVID, these were in-person sessions. But Vanderbilt trained their mentor participants a little bit later. So it was mostly done on Zoom. And so these were 4 training sessions, and we used the IMB model, which is information, motivation, and behavioral skills. And we really focused on some of the topics we talked about earlier in the podcast, which was metrics of dry weight, what fluid overload feels like, how you can reduce fluid overload using dialysis, and then metrics of nutrition and what clearance is, and how symptoms of uremia or infection may be related to access. And then the motivation part was really to instill self-efficacy and this perception of social support to kind of motivate these individuals to advocate for themselves. One thing I'll say, so the first 2 modules were mostly didactic about managing fluid and recognizing problems with dialysis access and what things you can do for ambulatory sensitive conditions that don't involve going to the emergency room. But the last 2 modules involved how to be a peer mentor. So how to impart self-efficacy, boundary setting. That was something that I had to learn in my preparations for the training sessions. Confidentiality. These are all part and parcel of being someone's mentor. And then also motivational interviewing, which I started using on my children, and non-judgmental listening. And then, of course, goal setting. That was really important in our training because we wanted these mentors to not only motivate and activate their mentees to do better, but give them the tools with which to do that. And goal setting seemed to be an essential part of that. But one thing I wanted to say is that I was pleasantly surprised because the mentors participated enthusiastically and showed up to every training session. And these are, don't forget, these are people who are getting hemodialysis themselves. A lot of them worked. A lot of them would get ill during the course of the study, but it was so inspired how they wanted to pay it forward. And I feel like this gave them a sense of purpose to help their fellow dialysis patients. And I don't want to get too emotional on you, but that was, I think, the highlight of the whole training session. So, and we paid them a very small amount of compensation for participating in the training, but that was a really amazing experience for all involved, I
Mhm,
think.
mhm.
Yeah.
It's almost an outcome of itself, maybe,
Yeah,
for a future trial.
definitely.
So let's talk a little bit about the results as that get to the exciting piece. What were the main findings in the intention to treat analysis?
Yeah, so the intention to treat analysis did not show a significant reduction in hospitalizations and ED visit events in those patient participants who were randomized to intervention as compared to those randomized to usual care. But some interesting side notes on that. In the Bronx, the intervention group did have a significantly lower hospitalization and e-visit rate. Now, we had 140 or so patient participants in the Bronx and 60 in Nashville at Vanderbilt. So in the Bronx, there was a significantly lower event rate in the
And
intervention, but
these were, sorry to interrupt, but
no, it's okay.
this was not like a trivial effect. It was a really large
Yeah,
effect.
yeah, we were surprised. And but not in Vanderbilt. And we also found that, and I'll explain why we think this happened in a minute. We also found that in the Bronx, the mentor-mentee pairs engaged in telephone conversations for longer periods of time and more frequently actually than in Vanderbilt. And one of the things we surmised was that during our study period, of course, COVID hit us with a bang and everything was stopped. And Vanderbilt enrolled participants slightly later than us. And so we think that because of the training interruptions and because probably individuals, they were just like more anxious and had other priorities, they were thinking about like a worldwide pandemic. I think it was harder for them to maybe engage in the intervention as much. But the other thing that we looked at was we actually had the mentees rate their mentors in terms of their style and their communication ability using a validated questionnaire. And the mentees in the Bronx rated them higher than they did in Nashville, even though both sets of mentees rated them high. It was slightly higher in the Bronx. Again, going back to the timeline issue, I think. So the other thing that we found was that we had pre-specified 20 minutes of telephone contact as the definition of as treated for the as treated analysis. And we found that in as treated analysis, actually, there was a very significant in reduction in hospitalizations and ED visits among those assigned to intervention versus usual care, randomized intervention versus usual care. This was honestly very surprising. Of course, we can't take too much, we can't place too much import on these findings because obviously the as treated analysis was not powered to show the difference, but it did suggest that the longer there was like almost a dose response effect, where the longer the connection was, the more effective it seemed to be. And so, if nothing else, this was really a signal for hopefully future trials where the telephone engagement is really the key, I think, to the outcomes. And I'll mention something else, and that is our secondary outcomes we thought of as mediators for how peer mentorship could reduce hospitalizations. So we looked at interdialytic weight gain, mean interdialytic weight gain. We looked at dialysis adherence. And we also looked at metrics for nutritional status, the serum albumin and the dialysis unit. And we did not find any difference in the secondary outcomes between the two randomized groups. And that was also fascinating because clearly what we were seeing was not being mediated by, necessarily better adherence or lower interdialytic weight gains. So that was interesting to think about as well.
So that's really fascinating. So let me see if I can sort of summarize it and then probe a little more. So we didn't see any effects in the intention to treat analyses, but the as treated analyses suggested that those who were exposed for a longer period of time to the intervention or had more in-depth exposure to the intervention found significant benefits. And that was also suggested by the analyses in the Bronx versus Vanderbilt because of how this got rolled out and how COVID affected it. But you didn't see any effects on the secondary outcomes. So I guess the question, the central question that I'm thinking is like, well, so what is the mechanism of benefit here if it's not teaching people how to manage their intradialytic weight gains? What do you think is the mechanism of reducing hospitalizations?
So clearly, Manju, we gave this a lot of thought. And my co-PIs were a little bit frustrated with me initially because we also used a huge number of validated instruments throughout the trial to look at change in scores on instruments that measured things like depression and self-efficacy and perception of social support and knowledge about dialysis. And, one of the co-PIs, Dr. Kavanaugh, is very well versed, obviously, in these instruments and health literacy. So we really wanted to capture, what these mentors were doing, if anything, to the mentees. And while we didn't find, glaringly statistically significant differences in terms of the change in scores over time, we did find a few signals. And for example, the depression scores we think may have improved more in the intervention group rather than the usual care group. And this was more around the 3-month mark, which was right after at the end of the intervention period. But also the depression scores also remained lower towards the end of the trial as well, just not statistically different anymore from the usual care. And then the dialysis knowledge scores improved significantly right after the intervention period at the 3-month mark, and as did some aspects of healthcare quality of life. So we think, I'll just mention one more thing, and that is in pre-specified subgroup analyses, we actually found that the reduction in hospitalization events was significantly lower in the intervention group versus usual care group in our Black patient participants. And it wasn't different in all of the other subgroups. And I'll just mention that we matched mentor-mentee pairs by language, race, sex, and age in that order. And so what we think probably happened is that it was really the emotional support and the sense of, having a partner, so to speak, in your journey through this disease, someone who understands you and someone who doesn't judge you and someone who can be a role model of sorts for you. That was what was driving this change in hospitalization rate again, I want to proceed with caution. It was not powered. The as treated analysis was not powered to show that. But if we had to guess as far as a mechanism, I think, dialysis patients who maybe go to the emergency room because they're anxious about what they're feeling or they don't understand what's going on with their body, they might just run to the emergency room. Whereas these patients felt maybe had a little more agency and felt a little more support to try and use their resources a little bit better and perhaps not have that sense of anxiety to run to the emergency room. And I think that this might explain why the Black patients we saw an effect in them because they maybe had a lower baseline level of trust in the healthcare system and may be more sensitive to the patient level, support that they got. But of course, all of these are theories and need to be probably explained and examined in future studies.
I really love how you sort of conceptualize that as an intervention that fosters agency and maybe I'll add resiliency perhaps. And that may be more important than any sort of pharmacologic treatment or change to the dialysis prescription that we can make. In the last few minutes, I want to just sort of take a step back and think through. Imagine you're a dialysis director listening to this podcast. What should they be thinking about if they want to implement a similar program? Is this ready for prime time, do you think, or what new evidence do we need before it's ready to be implemented?
I mean, I personally, this has been a labor of love for me, so of course it's ready to to be implemented. But no, I think larger trials are definitely in order because, as I mentioned, our intention to treat analysis did not show a hugely significant effect. However, I think peer mentorship can definitely serve as a source of social and informational support, and the modeling of, say, a mentor for their mentee can serve to increase self-efficacy and make a difference in their quality of life. I mean, don't forget, mentors are in a unique position to understand not just the mentee's clinical journey and their struggles, but also their sociocultural realities. And especially in our program, where the mentors and mentees were from the same neighborhoods and the same general areas. And so I think that's in this way, mentors can really, I think, hold the key to some of the communication educational gaps that are missing right now in hemodialysis care. And I think any mentor training should really encourage the use of the mentor's personal experience to provide social modeling. But, I think like with any program, care should also be taken because we need to make sure that the mentor's knowledge base is solidified so they can identify realistic and pragmatic ways where they can circumvent the shortfalls in dialysis care that lead to hospitalizations. And we want to make sure that the advice that's being provided is not harmful in any way. And mentors are not really paraprofessionals. They're really just sources of culturally tailored, I guess, support, I would say, for patients who are struggling with self-confidence or self-efficacy. And then I think what was really important was, these mentors, we trained them and they loved it on the non-judgmental listening and motivational interviewing that conveyed, I believe, that sense of social support that effectively really benefited their mentees. So, these programs require investment by, dialysis directors, not just in personnel, time, and financial incentives for the mentors, but also in promoting programs, making sure to creating an environment in the dialysis facility where patient-centered outcomes are, emphasized and where the voice of the patient is considered valuable, even when it comes to directing some of their care. And I think that's, again, what can be leveraged and what may be missing a little right now.
Well, Ladan, thank you so much for sharing your insights on this really exciting topic with our listeners. And again, congratulations on successfully conducting this really important trial.
Thank you so much for having Manju and allowing me to kind of describe away my labor of love in peer mentorship and dialysis. Thanks.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.